for grand rounds today. We have Dr. Rob Myette presenting today, so I'll introduce him in a second. And first, acknowledge that we're built on the unceded Algonquin and Anishinaabe territory, and the peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia. We honor them in this land. So today we're going to hear from Dr. Rob Myette. Rob, I think many of you will know, he's we were just discussing how long he's actually been at CHEO. He's been at CHEO about 5 years, and is joining us formally in January 2025 as a staff member to start as a clinician scientist at CHEO and the CHEO-RI, and we'll have a translational research lab in the Kidney Research Center here at OHRI, U Ottawa, CHEO-RI. So excited to get that, to get him started there. His work is targeted at understanding the molecular underpinnings of pediatric nephrotic syndrome. I think I skipped the line where I say he's a pediatric nephrologist. So that explains his interest in nephrotic syndrome. Through this, he is focused on delivering molecular signatures to improve diagnosis and decrease steroid burden in order to improve the quality of life for children and youth with nephrotic syndrome. So I think some research that, you can immediately see some translational, aspects and potential benefits, depending on how it all pans out. So looking forward to hearing from Rob today. Okay, just get this shared here. Yes, is it still? No. Okay. And the floating pin. Okay. And how do we also? Yeah. There we go. Whoa. All right. Okay. Yeah, that's right. Okay. Well, thank you very much, Pranish, for the introduction, and thank you all for being here. And for those of you who are online, I'll try to stay here in front of the camera, but I tend to move around a lot, so we'll see. Today, I'd like to talk a little bit about what's new in pediatric nephrotic syndrome. And it might shock you to know that there isn't much that is new, in fact. And over the last 50 years, there's been a lot of research directed at trying to better understand what causes this disease and how to fix it. And we're still very much reliant on prednisone. And so throughout the course of this talk, you'll see maybe there are some avenues for us to improve our diagnostic capabilities and our treatment approach. So I can skip this slide here. So when talking to a diverse crowd, I like to introduce the kidney a little bit because sometimes I hear people saying, the kidney, I don't remember anything about the kidney, go away. So obviously this is just the kidney on the left and a cross-section of the kidney on the right. We're going to zoom in a little bit closer. So on the left-hand side, we have the glomerulus. And the cells of interest for this talk are the podocyte cells, which are in green, which are within the glomeruli. Yes, exactly, here. And then to the right of that, or left, depending on your orientation here, you'll see electron microscopy pictures of this glomerular basement membrane highlighting the podocyte foot processes. And the reason I'm spending so much time on this is because nephrotic syndrome is a podocytopathy. So it's really localized to these podocyte cells, which are a little bit difficult to think about in the day-to-day life. We have millions of glomeruli per kidney, so you can imagine we just have hundreds of millions of podocytes. And throughout this talk, you're going to think to yourselves, maybe, this guy really loves podocytes. And actually going back to 2018, I gave grand rounds in Kingston, and I still love podocytes equally as much. So Bob Connolly put this on Twitter due to the extent of my excitement. So this is sort of our classic child who would present with nephrotic syndrome. Generally speaking, lots of periorbital edema. Usually the story will also, you'll hear abdominal discomfort, lower urine output. And many times we hear about allergies. So mistaken for allergies initially,
treated with antihistamines without any reprieve, and then presenting later actually in extremis from the nephrosis. Usually we hear about this presenting with an infection. So there's usually a upper respiratory tract infection preceding this. However, that is not always the case. Now, before we dig too deep into the clinical presentation, I want to take a step back to look at the etiology of this disease. So this is what's been a little bit confusing over the years. And even now, there seems to be a shift in the nomenclature. So many of these terms, focal segmental glomerulosclerosis, minimal change disease, these are histological diagnoses. This is looking through the microscope and seeing that. And for the longest time, people were comfortable just saying this is the disease. But truly, it's the histology. So we're sort of taking steps backwards now to better understand what is the disease. Oftentimes, minimal change disease is now referred to as idiopathic nephrotic syndrome. And there's probably even a shift to moving towards calling it steroid-sensitive nephrotic syndrome. But I won't bore you too much with all of this information. This is going to be the majority of what we talk about today because it's the most common form of nephrotic syndrome, in children. We'll only touch briefly upon secondary forms. In most cases, we identify that there's an issue, whether it's glomerulonephritis, an infection, a drug of some sort, a malignancy that causes nephrotic syndrome. And as soon as we intervene on that secondary cause, usually the nephrotic syndrome will go away. So it's not as exciting to talk about over the course of grand rounds, for me at least. So we'll shift gears, looking a little bit at what we call genetic nephrotic syndrome. So on the left of the panel here, you'll see these podocytes, which we looked at earlier, and then just amplifying that view. You can really see there are a variety of genes that have been identified, over 50 on this slide alone, that have been implicated in causing monogenic nephrotic syndrome. And so these children are typically presenting with either congenital or infantile nephrotic syndrome, which simply defines the timing, 0 to 3 months versus 3 to 12 months. And in almost all cases, these children will have renal failure by the time they're 2 years old. It's just simply, we cannot correct the monogenic disease. So they progress quite rapidly. We've done a bit of work with some colleagues in the United States. This is not to dig deep into the genetics. I'm not a geneticist, but just looking at some of the characteristics. So how we manage children with CNS and INS, so congenital and infantile, whether or not they require removal of their kidneys. And in many, many cases, they will have to have removal of their kidneys because of ongoing proteinuria. And then the types of mutations that are being identified largely seem to be frame shift mutations. But there's more work within these papers if anyone's interested, and I'm going to just move ahead here. So FSGS, or focal segmental glomerulosclerosis, again, a diagnosis of histology. So on the right side, this is what's called the glomerular tip lesion variant. I'm just showing this slide to highlight that there are approximately 5 forms of FSGS. They can associate with different conditions, different infections, different medications. But we could spend hours talking about FSGS alone. So this is just a highlight. Maybe in the future, this is something that I can talk about. But today, I want to stick with minimal change disease, or idiopathic nephrotic. So I really like diagrams, as is evidenced so far by my slides. And I really like the podocyte, obviously. And so this is, again, podocyte foot processes highlighting all of the intricate protein relationships that support the podocyte in order to maintain this ultrastructure. So minimal change, or idiopathic nephrotic syndrome, is thought to be an immune process. So something from the immune system is driving this disease, whether it's a B cell with an antibody, cytokine. There's lots of evidence to suggest that is the case. And most recently, autoantibodies have been discovered against nephrin, which is actually localized here in the slit diaphragm. So in 30% of cases in both children and adults, they can identify an antibody to nephrin in the bloodstream during times of disease, and it goes away during remission. So really pointing a direction towards the immune system here. So at first, we saw a picture of this young man here with his nephrotic syndrome. And in cases like this, we will give these children prednisone up front. just based on this figure here. So the majority of people with minimal change disease, which I was saying earlier, may now be called steroid sensitive, or we think it's more steroid sensitive. Around 80 to 90% of children presenting around the age of 5, so the toddler ages, will have minimal change and therefore should respond to steroids. So again, this is our classic presentation of a very edematous young child, and our approach would be to use prednisone. Before we give them prednisone, we do a variety of investigations to make sure that it is in fact this idiopathic nephrotic syndrome. While we feel very confident based on the clinical presentation and the age, we also want to do some screening to ensure we're not looking at a secondary form of syndrome. So really, the best test is a urinalysis. As simple as that. We dip the urine. So you see a child who has edema, dip the urine. If they have proteinuria, then that will drive investigations towards determining, is this nephrotic syndrome or not? We need to look at the amount of urine protein, the serum albumin, and we oftentimes will look at cholesterol. There's this relationship between albuminuria and hypercholesterolemia. We add on things like kidney function, which we'll talk about later on. These children are prone to having an AKI. Serum electrolytes, so occasionally they will have perturbations in their electrolytes. We look at complement C3 and complement C4 as a means to help us decide it is not something more complicated. It is the simple idiopathic nephrotic syndrome. Based on response to steroids, oftentimes they'll have a renal biopsy or genetic testing, or if they're diagnosed with nephrotic syndrome at a young age, they almost exclusively will have some genetic testing or a biopsy. And we drive many additional investigations based on whether we think it's a secondary form. So proteinuria, obviously we need to know what does that mean. It's not just a catch-all. We have some features that we look for. So depending on which textbook you look at, so for people studying for Royal College exams, this is not helpful. We could say greater than 40 milligrams per meter squared per hour. It's a very challenging one to calculate, I think, in the mind. If we look at the protein to creatinine ratio, which we can do in the lab here at CHEO, if it's greater than or equal to 0.2 grams per millimole of creatinine, we say it's a nephrotic range proteinuria. If we're in a limited resource area and we're unable to actually do these calculations, the dipstick can suffice, so greater than 3+ on a dipstick, as long as there is the evidence of low albumin and edema. And then those are also our other features here, hypoalbuminemia and edema. So we talked a little bit about how we approach these children now. So let's say we had our young man we saw in the corner. He's very edematous. We dip his urine. He's got 3+ protein. He's got hypercholesterolemia. He's otherwise got negative complements. He seems like a very classic minimal change disease or idiopathic nephrotic syndrome patient. So we approach this by giving them steroids. So our approach, our guidelines suggest we should use 6 weeks of steroids at 60 milligrams per meter squared, maximum 60 milligrams, and then 40 for 6 weeks, max 40 every other day. So you can imagine that's a very huge burden of steroids. And I don't know, I don't see any endocrinologists. Oh, yes, I do, yes. So oftentimes at the end of these talks, people will say, well, what's your taper? So depending on which guideline you follow, there could be either an abrupt stopping or a taper. And so Dr. Saleh in Kingston used to be a little bit upset by that. And that's not to mention, this is the treatment approach for an incident case. So you can imagine if we're having a child who's experiencing remitting and relapsing disease, particularly frequently relapsing or even steroid dependent, their cumulative steroid burden is massive. But looking at some data now from papers that have been published in this field, this was done by Carter and Kidney International Reports. They were looking at a large cohort of kids with nephrotic syndrome, so 631, quite a big group of children with this disease. And they had identified that about 7% were steroid resistant. And then the outcomes, forgetting you're online here, sorry, the outcomes are listed here below. So if you follow these blue arrows, you'll see those who are steroid resistant at baseline, some of them actually will obtain complete remission. Some will be infrequently relapsing, some will be frequently relapsing. What's important here is that there is a percentage, albeit a low percentage, that will have no remission ever. Whereas the steroid sensitive group, none of them ever seem to achieve no remission. They often need a secondary agent. And what's very reassuring in this situation is that there's a low percentage of children who have sort of a classic nephrotic syndrome, so this minimal change disease, who will end up with end-stage kidney disease. If you contrast that with the genetic forms, 100% of them will have end-stage kidney disease. This is just another way to look at it. This was done by Roland Perec, who's in Toronto. Just looking at the percentage in a study that they did, the percentage of children who required only steroids as treatment, required steroids plus a secondary therapy, or around 20% received steroids and then required actually 2 additional therapies. So you can see that there are subsets of these kids who require lots of treatment. And it's leading us to feel that it's a very heterogeneous disease. And in fact, it's probably not the same disease, where there's probably multiple diseases inside one umbrella. So this is the same as, I believe they were summarizing here. So this 1.7% probably of an initially steroid resistant group of people. So this is when everyone's eyes will roll back. Nobody wants to go through this. Even online, I can see the eyes rolling back. But these are the most up-to-date guidelines. I just wanted to flash them to show the amount of progress that's being made. If we rewind several years, it would be, you have nephrotic syndrome, there's your prednisone. There was not as much thought put into age ranges, but now we're starting to see there's this breakage point here. So if there are young children, they often are pushing people to do genetic testing quite early. This here is something we already talked about. So the presence of atypical features, and if they are present, then that drives us towards a kidney biopsy. But you can see here, no atypical features. Generally speaking, all 3 of these pathways converge on prednisone. So again, really the point I'm trying to make is these kids receive way too much prednisone. So again, I don't want to go into too many details about how we get there, but if we start treating with steroids and within a 4-week period, we're not seeing any improvement, that's when we start to think about a steroid-resistant phenotype. So this just shows us across the top at the 4-week mark, what we should do at the 6-week or 4 to 6 week mark, and then further down. And you can see this really stretches out. So when we're working through this can stretch out to 2 years. So we may have children who are almost continuously nephrotic for that long of a period. It is less likely, but it does happen. What I find really interesting here is enroll in a clinical trial. So I'm really happy that we're starting to build this into guidelines to say there are newer medications that are probably better, so let's try them. So what are the secondary therapies? So here, you might see on the previous slide, they were talking about 4 weeks, 4 to 6 weeks. This is an older paper, so around 8 weeks, they're saying. So you can wait up to 8 weeks for a response. If there is a response, you have steroid-sensitive nephrotic syndrome. If you have infrequent relapses, as we saw with the previous data, it is very likely you'll have a long-term remission. As we move into those who have frequently relapsing or steroid-dependent nephrotic syndrome, we start to need to use different medications like cyclophosphamide, tacrolimus, MMF, rituximab. But there is a futility arm in this wheel. So suggesting if we're really getting no response at all, we should discontinue our immunosuppressive therapy and use an ACE or an ARB just to target proteinuria and antifibrosis. When we're getting to that point and we're admitting defeat, it usually means that we need to shift our direction towards a kidney transplant eventually. And so why are we interested in driving these? Do you want me to go back? No. Okay. No. Yes, that's right. Yeah. So levamisole, that's used in largely in other countries that maybe don't have access to cyclophosphamide or tacrolimus. It actually works quite well. That's right. It actually works really well. The data suggests that it works really well. So maybe we should start using it. But I don't think we can get it for that indication here. So maybe that's our problem. So the reason we're so focused, I keep talking about we need to drive this disease into remission. We also need to spare steroids, but we need to drive them into remission is because if we don't, the risk of complications is quite high. So anybody who's ever done teaching with me, maybe they're online, but I see some people in the room, I think they'll see me do this a lot, which is the glomerulus, the podocyte foot processes. And I'll always share with them, all you need to remember is proteinuria. Just remember they have proteinuria, because if they have proteinuria, they likely will have hypoalbuminemia. And if they have hypoalbuminemia, they will have edema. And those are the 3 diagnostic criteria. So there it is, the Royal College, all 3 of them right there. Just remember proteinuria. But what's important is it's not just albuminuria. A variety of other proteins are lost. Immune globulins, antithrombin 3. So there's a coagulopathy. There are other risks that are associated with this condition. The first is edema. So again, eyes rolling back, physiology, papers from 2001. But I actually love this paper. This physiologist was looking at oncotic pressure and the differences in vessels in the nephrotic state. And they've actually contributed huge amounts to our understanding of this overfill versus underfill hypothesis. What this is basically our nephrotic patients retaining fluid and overfilled in their vessels, or are they retaining fluid in their interstitium and then in fact they're underfilled? And we need to assess this because this is what provides the risk for an acute kidney injury. So we use urine electrolytes to help us with this. And if warranted, as many may know, just from seeing nephrotics in the hospitals, we often are giving albumin, and Lasix. So that's to try to drive fluid back into the vessels and then opportunistically giving Lasix to drive that fluid out. And it seems to work at our center. Many other centers are not impressed by that approach and they don't use that approach, but we do here and we have good anecdotal data to suggest it works. So in fact, yes.
The underfill, where can it go?
So I tend to lean towards this idea that I believe it's the underfill until the point of transitioning between disease and remission. When they start to bring mobilized fluids on their own, then they typically can be hypertensive. Yeah, that's right. But then they should start to void. So it feels to me, and I'm, the other nephrologists here, I don't know if they'll agree or disagree with me, but I feel the underfill fits most. You can see this interstitial edema. It's right there in front of your eyes. And then often they have markers of low filling in their blood vessels. So infection is another big issue here. So we have a child who's immune compromised as a result of their disease, losing immune globulins in their urine. And then we immune suppress them with prednisone or some even steroid sparing agents. So these children really are at risk for infection. And the big one that we're most concerned about, the big one for the Royal College, because I know that there could be some people who could be studying, so I keep saying that, is spontaneous bacterial peritonitis. So strep pneumonia is the leading cause of that, which I also find very interesting. So what do we do about this? So we really ask that these kids receive their immunizations and we counsel them on high risk, I don't want to say behavior, but if they're really immune suppressed, we may ask them to wear a mask when they're around their peers, those types of things. And often we talk about prophylactic antibiotics where the evidence is a little bit murky. So there's no one who's come right out and said, you need to treat them with antibiotics when they're nephrotic. So this is a rather severe case when looking at the image. This is peri vena cava syndrome. This happened here at CHEO. So venous thromboembolism is a big risk. So these children have abnormalities in their platelet aggregation. They have issues with coagulation, loss of anticoagulant factors. And so they're prone to having venous thromboembolism. And if we were to put a PICC line in, for example, we increase that risk exponentially. The evidence to anticoagulate prophylactically also is not quite there. But in our cases here, because of this exact case, if there is an indwelling line, we are reaching out to hematology and asking them to help us to provide the prophylactic anticoagulation. Acute kidney injury. So we talked a little bit about this already, and I think it's easy to kind of make that connection. They have low intravascular volume. Their kidneys are being exposed to less volume, and so they have an AKI. The children we manage as outpatients often don't have AKI, but the ones who require admission, in a case series, it was up to 60% of them had elevation in their creatinine. So another risk factor for these kids. It's probably the combination of the disease, diuretics, and potentially infections that can worsen this. So again, we're obsessed with urine electrolytes. We just get our urine electrolytes. It gives us a little bit of information to help us better understand the intravascular filling. Hypercholesterolemia. So I alluded to that earlier. So these children have elevated lipids as a result of their disease. This gives them or leads to early cardiovascular disease risk. And there's a lot of evidence coming out now in young adults who were nephrotic, who had quite bad nephrosis earlier on, who now have early signs of cardiovascular disease. And so while not often do we do this, we would consider statin therapy in children who are persistently nephrotic or frequently relapsing. And lastly, elevations in blood pressure. So this risk of cardiovascular disease. So we're adding on all these other factors. So now high blood pressure, intermittently high blood pressure, or persistently high blood pressure in children who have proteinuria. And in the study that we did here, actually, we saw that it was diastolic blood pressure actually that was elevated in the context of proteinuria, which was an interesting observation, and we're sort of chasing that right now. So everyone's still awake. Well, that's good. Hopefully online, everybody's awake. What do we need to do next? So I didn't really add all that much to what's going on in pediatric nephrotic syndrome. And to be honest with you, that's because there haven't been any massive monumental changes, at least in our treatment approach. So what do we need to do? So we need to get a better understanding of the etiology of minimal change or of idiopathic nephrotic syndrome, however we want to refer to it. Further characterization of the genetic forms. We get a better understanding of what's going on early in life. Although I think despite any new knowledge in the genes, for example, I don't think we're going to change the outcomes yet until we maybe can have genetic therapies. Do we have new treatment modalities? So can we reduce the amount of steroids? You're going to be tired of me saying that, but it's important. Can we reduce the amount of steroids that these children receive? And what I'm really interested in and what I want to move forward is looking at the podocyte. As I said before, I love the podocyte. So I really want to spend time better understanding it. I think it's central to this disease. So here, it's a natural target for study. Nephrotic syndrome, podocytopathy, we should study the podocyte. And so what I'm hoping to do throughout the rest of my career, this is just a glimpse, but the bottom line for me, you probably won't be surprised, is we want to reduce the steroid burden. So that will directly increase the quality of life for children with nephrotic syndrome. The three arms I'm interested in looking at is, can we study the podocyte? Can we better understand what it's doing in the context of disease? And can that inform us as to better therapies and new avenues of research? I have an interest in mitochondria. So you may recall from the previous slide where I showed the zoom in of the podocyte, there were mitochondrial genes that were altered. So I'm more interested in the mitochondrial function in non-genetic forms. And then can we develop a better non-invasive biomarker of steroid responsiveness? So therefore, if that is present, but absent in others, we may be able to move our dial, skip steroids, start steroid sparing therapy first. So podocyte effacement, things are going to get a little bit more molecular now. So maybe, again, eyes might roll back or they might open widely. So when we look at this disease, these podocytes, again, I like to do this, when they efface, they flatten. That's an active process. That's usually a stressful process. And through my PhD, I've been very interested in something called extracellular vesicles. So without going off the deep end here, these are small particles that come off the parent cell. So I'm interested in the large ones, so that's here. These vesicles come off the parent cell. They retain characteristics of the parent cell membrane, as well as the cytosolic components. So immediately learning of these, I thought to myself, this is like a liquid biopsy. So the podocyte faces the urinary space. You stress out the podocyte, they release particles into the urine. So we can collect urine non-invasively, and we can better understand what's happening in the parent cell, which is up in the kidney. The only way for us to do that now is an invasive biopsy. And we don't always have clear indications for a biopsy, and there are risks associated with that. So what did we do? Simple. We enrolled, well, maybe not so simple with the REB, but we enrolled children with nephrotic syndrome, collecting urine samples during disease and during remission. And we profiled the extracellular vesicles, or the particles in their urine. We did that using podocyte specific, so my favorite cell, podocyte specific antibodies and flow cytometry. And we were able to show that during times of disease, there are massive amounts of these EVs in the urine. And during times of remission, there are very few. And in many cases, because these are biological data, so there's obviously some variability, but in some instances, these children had 0 podocyte EVs or particles in their urine. So we thought, we're kind of onto something. At least I thought so. I still think so. So we tried to translate this into the lab. So we went the other way. We took this finding. We are growing human podocytes in culture, and we're treating with this drug here. It's called puromycin, or PAN. I'm going to refer to it as PAN. And basically, it's a glomerular epithelial cell toxin, which means it's a podocyte toxin. It injures podocytes and is well described as a model of nephrotic syndrome in the lab and in animals. So we're injuring podocyte cells, we're collecting our particles, and we're characterizing our particles. So this is an old picture. I still showed it because I think pictures are cool, and they speak 1,000 words, or whatever the expression is. You can see control podocytes in culture here. Green is referring to phalloidin staining, which is related to actin. So it's related to the appendages of the podocyte. Blue is the nucleus. And you can see when we treat with our puromycin, so we injure these cells on purpose, we see an increase in stress fibers. So these cells are starting to move. They want to move in a different manner than when they're under control conditions. So this was just to make sure that puromycin, or PAN, would actually do something. So we did determine correctly it did. Now this, again, eyes rolling back. So we're going to talk about cell culture. We're talking about podocytes in cell culture. And the numbers I'm showing in these graphs are the particles coming off of them during times of injury. So you can see after a 6-hour treatment with PAN, we saw no increase in particles, but after 24 hours, we did. So basically what I'm walking through is how we are generating a model to understand these EVs in culture, or these particles in culture. Did a second experiment. Now I'm really fast forwarding a lot of the grunt work of the PhD, but I'm here. We thought, okay, so let's give them prednisone. Let's give the cells prednisone and see what happens. And much to our surprise, or not surprise, we found that when we treat with prednisone, we inhibit this effect, these particles being released quite considerably back to control levels. And we spent a lot of time trying to mechanistically better understand what we're doing here. And it seems it's oxidative stress. So this last graph, MDA, malondialdehyde, is a marker of lipid peroxidation. So it's a marker of oxidative stress in cell culture. And so we were able to show, not very convincingly, but convincingly enough, that after we treat with PAN, we drive oxidative stress within these cells. And then again, by using prednisone, we can return that to even less than control. So it seems to have some sort of a protective effect. Next, we wanted to say, okay, so this is sort of my third arm of that overarching research program. We're looking at these as biomarkers as potentially steroid responsive. And so we sort of switched to doing some proteomic analysis. So for those of you who haven't seen this before, it might be a little bit confusing. So basically the first graph on the top, all that's trying to show us is that there's a difference in the proteome between our control and our PAN-treated cells. So podocytes in culture treat with PAN, EVs are released, capture the EVs, send them for proteomics. So can they recapitulate what's happening on the parent cell? And so this is very new. I just got these data just a few days ago, so I haven't even really thought much about it. But some of the targets that you see on what's called this volcano plot, if they're shifting to the right, for those who are here, it's probably the same on your screens out there, you'll see that these are actually proteins that are upregulated in the particles when we treat with this drug PAN. So the next thing we're going to do, this is again very preliminary, is we're going to approach using human EVs, excuse me. So this is just a very preliminary result. We took EVs from children who have nephrotic syndrome during times of disease. We isolated those particles from their urine and we sent them for proteomics. So we've identified a significant number of proteins within these EVs that cross a variety of different functions or locations in the cell. And what's very interesting, obvious, and I think is obvious, is this response to stress. So we talked about how the podocytes, when they're injured, they move. It's a stressful event. They're packaging a bunch of these stress proteins into their EVs. So we're actually seeing that there are markers of cellular stress in the particles that we can reflect back on the cells.
So Robert, number of proteins identified and given the pathway, further to the right, the more number of proteins are.
Correct.
And then the less.
Yeah, the blue is actually here. It's showing the significance. So I'm collaborating with a proteomics guy who really, this was very clear, very obvious to him, and I need to ask him some additional questions really about this, but I thought it looked pretty nice and it was pretty fancy, so I showed it. But I think, yeah, exactly. So what I'm most interested in when I look at this is just our ability to identify a large number of proteins in different biological categories from particles released from cells. That's what I'm most interested in. And so this might feel like a large jump, but one of the proteins we identified is related to mitochondrial health. This is how I'm trying to spin in a little bit about the mitochondria. And I promise I'll stop as I see eyes rolling. No, I'm just kidding. I'm kidding. We have 5 more minutes of mitochondria. So here you can see, yeah, that's right. I know. So here we have our humans. So looking at EVs, again, particles taken out of the urine from children with nephrotic syndrome versus no nephrotic syndrome, we actually found that those EVs had mitochondrial DNA in them, which to me, it was a very interesting finding, a very unexpected finding. And so we're really chasing this down, trying to understand why would a cell package mitochondrial DNA into an EV and then release it. It's seen in the human condition, so in nephrotic syndrome. Also, when we went into the lab, it was a much more exquisite response. So again, we took our cells, podocytes, we treated them with PAN, we captured the particles that were released, and they were hugely filled with mitochondrial DNA. So they had a 30-fold increase. And again, we saw this beautiful recovery when we treated with prednisolone. So whatever we're doing when we treat with prednisone, we're impacting either A, the mitochondria themselves, or B, the ability to produce EVs. And that's why there's such a reduction. Last one, I promise. So here we looked a little bit further. So many people here are probably not familiar with what's called the seahorse assay, but I think Alex is. So seahorse assay, to really just summarize, is a plate assay. We're studying cells, and basically we're trying to understand how well the mitochondria respire. So how well do they use energy sources to respire? And so we anticipate they should have a specific kind of a baseline level. And when we treat with puromycin, so our drug of interest, we're injuring these cells. We all thought in the lab we were going to reduce the oxygen consumption. We were going to reduce their ability to respire, but actually we cranked it up, which is an interesting observation. Again, treating with prednisone seemed to abrogate that effect. It brought it down. And this is nearly finished, but we've really been chasing this down in the lab. We think we've isolated isolated it to complex 3. So we're looking in the treatment of these cells with PAN, a reduction in the amount of protein. So probably a reduction in function. But there isn't a reduction in function, there's an increase in function. So I won't go into this too much because I'm still confused about it, but I find it very interesting, and I think it's pushing us towards an understanding that the podocyte is very complex. It is central to nephrotic syndrome, and there may be new pathways that we can tease out. So this is a review we just put out. It's not even out yet, but this just shows the complexity of signaling within the podocyte. And this is largely based on our observations that there is mitochondrial DNA inside of these EVs and whether or not those EVs are signaling to other podocytes downstream through these pathways. So we won't talk much more about this. We'll go back to our clinical case. So look at this young man now. So he's in remission. This is the same boy I showed earlier. So quite a significant difference. So this is what keeps me going, being able to see that these kids can get treatment. We can bring them back to their normal self, which I think is great. So nephrotic syndrome is related to the podocyte. I think you're all aware of that now, based on my love of the cell. Minimal change disease is the most common form, but in the future, we're probably going to call it idiopathic nephrotic syndrome or even lumping it as a steroid-sensitive form. It seems to be related to immune dysregulation, but that's not very clear. And my last point, as everyone might anticipate, so we need to reduce the amount of steroids these kids receive. So I hope to do that over the course of my career. So thanks, everyone, very much for your attention. These are the people I have to thank most. So in the top panel, actually, this is Dylan, and this is Chris. They are my PhD supervisors, and the rest of the people in the group, they're from the lab where I'm working. And then ICEF 2023, that was just a big group of Canadians down in Seattle for this conference. And I thought it was a nice picture. So thank you to you all. Thank you to the nephrology group, all of these people here, and I'm sure there are people I've forgotten. So I'm happy to take any questions.
Thanks, Rob. I'm gonna take down the slide. Dylan's my backyard neighbor, by the way. I always remember that. There we go.
Well, Rob, while Chris is doing that, will Leanne's vamorolone work instead of prednisone, the new steroid, or not? Is it a conversation you've had with her?
We haven't. Yeah. Oh, yes. So what's the name of the drug?
Vamorolone, how do you pronounce it? It's a somebody might know better than me. It's a novel steroid which is bone sparing, apparently. That she and Eric Hoffman have come up with, and whether or not that might work in the product syndrome. Yeah. Maybe the next time you see Leanne,
I will.
You could ask her.
So the question was just around a new type of steroid that is bone sparing. I don't know the name of it, vamorolone perhaps, and whether we could use that in nephrotic syndrome. So, I mean, I can't say for sure, but it seems absolutely if it has the same type of immunosuppressive effects without all of the side effects. Let me talk with her.
Yeah,
that's great.
You're permitted.
Thanks, Robin. And before we get to Christian's question, I had a question that somewhat relates to Alex's. So I was really struck by your in vitro model of culturing podocytes and then exposing them to steroids and seeing the responses in both mitochondrial DNA and the EV constituents. I have to admit, with nephrotic syndrome, I always thought the steroid response was more of a cellular response and that the target wasn't the affected cell necessarily, but the cells in the organism modulating an immune response. So there must be steroid receptors in the podocyte, and what's that internal cascade was the first question I had. The second was, likewise, steroids' biggest morbidity has to do with the extra target, beyond the target of your therapy. So whether it's bone or immunological, whatnot. Are there any possibilities around podocyte targeting? And is this real? Right? Is it really a direct steroid effect intracellularly?
Those are two really good questions. I feel like I'm standing for my PhD defense right now. Yeah, well, thank you. So for the first one, yes, the idea behind steroids, I think for the longest time was, we don't know why they work. Like, why do they work? We don't know. Then as we're leaning more towards this being an immune regulated disease, it's probably by dampening the immune system. That's correct. There are glucocorticoid receptors on the podocyte. And there are studies, a lot of them are sort of in vitro and preclinical studies showing that they can have a massive impact on podocyte, the functions within the podocyte. So I'm not a glucocorticoid receptor expert, but thinking about the impact of binding that receptor and going into the nucleus and having a variety of proteins that would change. I think that, and that's not a good statement in science, but I think that, there is ample evidence to suggest that prednisone does have a direct effect on podocytes. In the human condition, whether or not that is in fact occurring, I'm not sure. And your second question was around whether just, can you rephrase it? Because I don't know if I remember exactly what it was.
The second question was, if what you were saying is
Yes.
correct, is there a possibility around cell targeting steroid therapy? So, you know, instead of exposing the entire organism,
I see.
is there something, you know, I don't know if there's
Yeah.
for other, there's so much, but, you know, exposing the podocyte in some sort of targeted way to the steroid.
Yeah, that would be amazing. The only thing I can think of that's in a similar vein is rituximab. So at first, rituximab was used to target B cells, and it works in nephrotic syndrome. That's really why it's pushing us towards thinking there's an immune mechanism. But some really smart people were looking at rituximab and how it can actually bind to the cytoskeleton of podocytes and stabilize them. So that's kind of an interesting observation. I don't think that's been flushed out in humans. I don't know how you would do that actually, but what you've just said is very interesting when we think about it. Thank you.
Thanks, Rob. That's interesting. So that's great. Christian.
So that one's answered. My follow-up question was going to be about the mechanical stress of proteinuria and how that relates to the podocyte, because I recall someone telling me at some point that proteinuria itself is damaging to the podocytes, and that's one of the arguments for not using albumin and basics when treating nephrotic syndrome. Can you talk about mechanical effects of proteinuria on the podocyte?
So yes, so the question was around the mechanical impact of proteinuria on the podocyte, and discussing whether or not that giving albumin might actually be more detrimental. So indeed, there are some studies that show, the term studies that show, they were in vitro, they were looking at podocytes in cell culture, and they were actually applying. So when you say mechanical, do you mean literally mechanical?
I'm just wondering about literally mechanical, because
Yeah.
there's lots of evidence in bone health and so on about mechanical stresses actually being able to change the behavior of cells.
So it seems, at least in the literature around podocytes, it seems that stretch or a mechanical transduction is actually bad for them in the context of literally moving. So they have some capacity to move. You can imagine the foot processes are on these glomerular capillaries. So with pulsation of blood flow, you can imagine they have to have some ability to move. But there's probably a cutting point where if there's too much movement, they probably are unhappy and they efface. Proteinuria itself indeed can be detrimental to podocytes, but it's more detrimental, at least I think, to the downstream to the tubules. So they're not used to seeing that much protein. They can deal with some proteinuria in the proximal tubule. They chop it up and reabsorb the amino acids. But really, with a high degree of proteinuria through the tubules, that's, I think, a driver of fibrosis. So indeed, you're right. When we give albumin and we give Lasix, we see a huge increase in the amount of protein in the urine. But we also see urine. And so that gets the patient moving, that gets the urine flowing, because otherwise, if we wait too long, they may become dialysis dependent. Not dependent, but they may require dialysis. So I think these are really good questions. I think that it's detrimental. Yes, it's been shown that it's detrimental, but it probably is one of the only tools we have that's effective. And I kind of skirted the question a little bit, sorry, but it's kind of hard to answer. Yeah. Yes.
Yeah, no, that was great. Well, you mentioned many of them have antibodies, and I was just wondering if you can measure that clinically, if anyone's looked at that, and then to help predict remission, relapse, or if you see high titers that have the course.
Yeah, exactly. That's an excellent question. That's what so there's a big group out of Boston, of course, out of Boston. Oh, thank you. So the question was just around using the antibodies to nephrin clinically. Can we apply that clinically? And the answer is yes. So the group that first discovered this, the Wines group, they're out of Boston, and it's a really big paper. There are other groups around the world who are A, they're validating the observation, but B, they're also applying it clinically. So they're starting to say, can we prospectively screen for this anti-nephrin antibody? But I don't think it's going to come, for example, come to us anytime soon. I think it's going to be in one of those huge centers, probably in the United States. They're going to do a lot of the work, and then they'll show us if it's actually worthwhile or not. But a follow-up to that, if I can bend your ear for one more minute, is there are other antibodies that are being discovered. So there's a group out of Montreal, Dr. Tucano's lab, and my friend Simon. They've been looking at another protein called CREB2. So they've actually been showing that there is anti-CREB2 antibodies that can be discovered that are targeting this location, the slit diaphragm. But no one's asked me the real hard question is, so how did these antigens get presented to these antigen presenting cells?
How do these antigens get presented?
No, so this keeps me up at night. I don't know. Nobody seems to want to address that. You go to the big meetings, you raise your hand, you say that, and then basically I'm shunned out of the room for asking the question. No, so I'm just trying to stimulate some discussion, but it's really how does it happen? We don't know. And I think that whole avenue of discovery and then application to translational therapies, we need to know how these antibodies produce how these immune cells produce this antibody. How do they receive the antigen?
Does it need to be a podocyte or even renal site for that? Could it be happening elsewhere, but it just happens that the cells are responding to generating podocyte specific response, but it's not happening in that area.
So that's a good thought. But nephrin's only expressed at that slit diaphragm.
Okay.
And it is relatively immunologically protected. So we look at these kids who have nephrotic syndrome, we look at their biopsies in the worst of it,
Right.
and we don't see massive amounts of infiltrating immune cells. So maybe there are some resident macrophages in the, we're not sure yet.
The puzzle is, it doesn't behave like one of Christian's true autoimmune thing. It's got a sort of Myette response to rituximab and stuff. So it's autoimmune with a twist.
With a twist.
Yeah. Well, figure that part out.
I'll try my best.
Okay.
So Alex making the point that it might be an autoimmune disease with a twist. Yeah, so it's not. Yeah, I just wanted to quickly check if there were any questions online. If there are, just put your hand up and we'll see it. Sort of along the lines of Alex's question before we go to Anne and Stuart. Alex, sometime during the talk, asked if the steroid non-responders were genetic. And I found myself wondering, are any of these not genetic, or is this simply a case of some are easy, simple Mendelian genetic conditions, but the others, has anyone tried to approach the question, are they complex genetic in the way that you might see with some of the autoimmune diseases that Christian treats, et cetera, where you have a more complex genetics? I don't want to say it's complex disease, but it may be, are there variants in nephrin that tie into variants in some of the other scaffolding proteins that predispose to antigen presentation? So is that a field of research that's ongoing?
Not that I'm aware of, but you've given me a great idea for a grant. No, just kidding. So I think you're absolutely right. When we look at these monogenic forms of nephrotic syndrome, it's relatively clear. Their presentation is quite clear. The genetics is quite clear. We have one gene that has a mutation, and this is the phenotype. But we have lots of children who have variable response to prednisone. So they initially respond, then they become frequently relapsing, then they become dependent. And we do genetics on these, and we often will find multiple genes, but nothing is clear. It never says pathogenic. It usually says either non-pathogenic or I forget what the other one is. Yeah, or exactly, a variant of unknown significance. So whether or not I like this idea of there's a complexity to multiple phenotypes related to the genotypes in these proteins, that is just an unfavorable grouping, and that's probably what it is. What I can't wrap my head around is why they would respond to steroids initially, unless the driving factor is maybe immune cells. It's very tricky.
Yeah, no, very interesting. It's kind of like you think about different possibilities.
I mean, I'm biased. So that's how I thought about it. But more of a distant, like, they talk about molecular immunity. A lot of these kids have receiving viral,
Yes.
whatever immune stimulation event. Why did it, how did it attack the active podocyte? Like, I would think there would have to be some kind of,
Mhm.
not sure how that really come into.
Yeah.
You bring up the fact that you're, you study the kidneys and you have this liquid biopsy again. Can you talk about that? That's kind of cool. Can you do like urinary cytokine profile? Like, are you able
Yeah.
to have signatures? Because I'm like, I agree, like it's probably a bunch of different, it's heterogeneous, you call it, like colored, minimal change.
Yeah,
They're
yeah.
sensitive, but they're different. So are you able to like measure everything in the
So yeah, that you can order, we haven't done it yet because there are other groups. Oh my gosh, I'm so sorry. I'm so not used to this. I gotta train. Yeah. The question was around so just highlighting the immune mechanism, likely immune mechanism. And then there was a question around maybe how viruses could predispose, but then also can we measure things like cytokines or other markers in the urine to help us understand these mechanisms? And so, yeah, that's a really excellent question. So there are some groups that have already done this. I can't pull that information right now for you, but there are cytokine profiles that differ between, say, relapse and remission. I was really liking the first part of your comment / question about viruses, and there's a group. His name's Tarak Srivastava. He's in the United States, and they're really looking at how specific viruses may, because they kind of are going everywhere, how they may actually interact with the podocyte. The podocyte itself has a lot of chemokine receptors, cytokine receptors. I'm not sure if we have a clear understanding whether there are receptors for different viruses. Now, that sounded funny maybe, but I mean, can they gain entry into the podocyte? COVID can. That's the consensus from the literature around COVID. So to think other viruses may be able to get inside of the podocyte, maybe they can derange the proteome of the podocyte. Maybe there is presentation of antigens that wouldn't otherwise be presented. That's a really good question. Yeah. Yeah. Exactly. Yeah.
Sorry, with the cytokine, were you able to target it, like with therapeutics? Like,
I might get Ann and
Yeah.
Rob to connect after because we have time, I think, for one more question. That clock in the back is slow, so we're actually almost at 9:30. So Stuart.
Is there any drug that exists right now that's non-steroidal, that you think we understand what's happening to podocyte more or potential for steroid sparing use? The other question was a practical one of if I'm diagnosing somebody with minimal change disease, like based on the criteria, or sorry, if I'm diagnosed with nephrotic criteria, how far into the investigation do I have to go for other causes before we can start treating? I need the emergency department. Can I start treating them there? We need to wait until everything comes back.
So the question was around treatments that are non-steroidal, so novel treatments, and then 2, how far to go in the emergency room before starting steroids with a workup for a child with kind of a presentation. So often what we would like, maybe if you've called us in the past, is I'm answering question 2, is we get the urinalysis, we get the kidney function, we get the elevated lipids, so hypercholesterolemia, the complements. And then some people argue we should do IgA and ASOT to make sure we're not looking at this post-strep GN, but that isn't always necessary, for example. Really, the complements are, I think, I'm going to speak for myself, I will kind of hinge on the complements. If they're altered, then I think we need to think about a different etiology for this presentation. And there are 2 monoclonal antibodies, whose names I can't remember, but they are currently under quite intense study in Europe. They are steroid-sparing monoclonal antibodies for nephrotic syndrome. So maybe in 5 years, we'll have some good information, which doesn't help us now. So thank you.
All right. So thanks again, Rob. That was an excellent grand rounds. Mix of basic science, translational science, and clinical application, and helping people with their old college exams through it as well. So thanks again, and we'll call that to a close tonight.
They vote for, we can